So switching gears to amblyopia, a very older and kind of a boring, confusing topic from the fancy myopia. So a quick recap of what is amblyopia. So it would be a unilateral or bilateral decrease in visual acuity caused by form vision deprivation or abnormal binocular interaction for which no physical cause can be identified and is reversible by therapeutic measures. So when one eye is input is not recognized by the brain, causes amblyopia. So it can be classified as stimulus deprivation, anisometropic, isometropic, and strabismic. So the first and foremost is in treating amblyopia is the elimination of the causage of the visual deprivation. So it could be a ptosis, it could be a cataract, or it could be a refractive error. So that starts the main treatment. But even after this has been corrected, the eye doesn't see properly. So that is mainly amblyopia. So why doesn't the eye see even after correcting the refractive error or clearing the visual axis? So what is the pathophysiology of patching? So the signals from the weaker eye are ignored by the brain. But we call the disease as a lazy eye, blaming the eye when the person who's lazy is actually the brain. So the brain refuses to recognize images from the weaker eye. So it says yes to the eye with no refractive error and no to the eye with refractive error, even after refractive correction. So how do we deal with this brain? So as long as the right eye is sending good inputs, strong inputs to the brain, the weaker eye inputs are going to be neglected by this brain. So what do? We patch the normal eye or the one without the refractive error so that the brain is forced to recognize the inputs from the weak eye and increasing the vision, thereby increasing the vision in the amblyopic eye. So initially, when patching was started, it was mostly full-time and there were other variants like inverse patching, and then it slowly shifted to part-time occlusion. So all these were based on the PEDIC studies. So these Pediatric Eye Disease Investigator Group conducted the ATS studies, amblyopia treatment studies, about 20 of them over a long period of time. And I'd like to summarize their results for practical application. So spectacles are an effective initial tool in managing amblyopia. When the cause is the refractive error, just prescribing glasses can improve the amblyopia in many cases. So they found that in severe amblyopes in 3 to 6 years of age group, 6 hours of patching per day is as effective as full-time patching. They also found that in moderate amblyopes and 3 to 6 years of age group, 2 hours patching is as effective as 6 hours patching per day. So there are other inputs where that patching is effective even in 7 to 12-year-olds. So we generally say that the amblyogenic age group is 7 to 8 years, and treatment beyond that may not be that effective. It may not be as effective as in low age, but there is some effect, significant effect in 7 to 8-year-olds also. And when coming to 13 to 18 years of age children with amblyopia, if they are treatment naive, that is, they have not patched at all before, they are likely to show some improvement with patching. They also found that atropine and patching are equally effective in the treatment of amblyopia. So another problem with amblyopia or with any other treatment modality is like the recurrence. So in PEDIC studies, they found recurrence to be about 21%. So to do all the work and then to have recurrence is really bad. So coming to my main topic, so when to start patching. So what determines when we start patching? We depend on the age of the child, the severity of amblyopia, and the type of amblyopia decides when we start patching. So for example, let's take this child, a 5-year-old with a BCV of 612. So if this is an isometropic amblyopia due to -3 D cell, will they need any treatment apart from glasses? Likely not, because during refractive adaptation itself, the amblyopia can improve even up to 6/6. So for refractive adaptation, we usually give 3 to 6 months of time for the refractive adaptation to happen, but should be closely monitored at least at 3 months intervals. So even beyond refractive adaptation, if the BCVA is not improving to 6/6, then we may need to start these children on patching. So coming to age, let's take these two children for example. The first child, a 5-year-old with a BCV of right eye 612 and left eye 6/6, and anisometropia due to astigmatism causing the amblyopia. Comparing that to a 10-year-old with a BCV of right eye, same BCVA, right eye 612, left eye 6/6, and the same cause, anisometropia due to astigmatism. In this younger child, since it's in between the 7 to 8 years of age group, I would like to prescribe glasses and wait for the refractive adaptation to happen. That is the child beyond the 7 to 8 years age group who's already 10 years. I will not want to waste time with only glasses and waiting for refractive adaptation. We can start patching along with the glasses. We may need to start. He may not have the time to catch up on the vision if we wait for refractive adaptation. So type of amblyopia also plays an important role in deciding how much to patch and the duration of patching. So let's take these examples. The first child is a 5-year-old with a right eye BC of 624 and left eye 66. But the type of amblyopia is a stimulus deprivation amblyopia. Let's say, for example, pseudophakia in the right eye with vision only 624. If we compare that with the age of 5-year-old same age child with the BCV of right eye 624 same, but if it is an anisometropic amblyopia, that child with anisometropic amblyopia has a better prognosis. So the duration and severe intensity of patching is going to be more for the stimulus deprivation amblyopia when compared to the anisometropic amblyopia. So amblyogenic factors for refractive amblyopia differs. So in coming to anisometropia, hyperopia has the most amblyogenic. Even one diopter of hyperopia anisometropia can be amblyogenic, whereas for astigmatism has 1.5 diopters and myopia it's more than 3 diopters. When it comes to isoemetropia, astigmatism has the least with the 2.5 diopters and hyperopia 5 diopters and myopia more than 8 diopters. So coming to severity. So let's compare these two children, 5-year-old with right eye 660, left eye 66 with anisometropic amblyopia, same age, but with a less severe amblyopia of right eye visual BCVA of 612 and 66. So same type, anisometropic amblyopia. So since the severity of amblyopia is more in the child with 660 vision, that child might need more intense patching and a longer duration of patching to achieve a target BCV of 66. So in pedic studies, they classified the amblyopia as mild, moderate, and severe. So the first child might require 6 hours of patching initially and maybe gradually tapered when they show improvement in BCVA. Whereas the second child, I can start with at least 2 hours of patching and then monitor. So now we know after this discussion about the age, type, and severity of amblyopia, how do we go about starting patching? So initially we can have a slow beginning and the steep acceleration. If you say 6 hours of patching to a child of 5 years, on day one, I don't think it will be possible for any parent to enforce a 6 hours of patching. So maybe we can start with 1 hour of patching for 1 week, increase it 2 hours of patching for 2 weeks, then 4 hours and 6 hours like slowly. So the different modalities available are the patch stuck directly to the eye or patches homemade from soft tissue paper and micropore tape. We have the Doyen's occluder or frosted lenses. The most preferable is the patch on the eye works best. So patching should ideally be preferably done at home under adult supervision, especially in cases of severe amblyopia where the child may not have adequate vision to perform normal functions without adult supervision. And contrary to many, there are no much reports that near activities or more concentrated like near activities like reading, writing, drawing increase the effectiveness of patching. So they can do any activity except sleeping. So how do we monitor? Once we have advised patching, when they come back, what all do we see? So the first and foremost problem in amblyopia is compliance. So it is mostly patient reported, so that is also not very clearly that we can monitor. The one thing that we can monitor is from the improvement in the visual acuity. So if there is improvement in the visual acuity, we can say that there is compliance to the patching. So when we check for visual acuity, usually the amblyogenic eye is tested first. In the amblyogenic eye, we check for improvement in vision. Whereas in the occluded eye, we check that the vision has not dropped, which is also equally important so that occlusion amblyopia does not occur. So in cases especially of strabismic amblyopia, we also see that the fixation preference is checked, whether even after BCV of 6 has been achieved, we check that the fixation preference is also equally dominant. Otherwise, patching may need to be continued. And stereo acuity also needs to be monitored during the patching. So now the $1,000,000 question, when to stop? The eager question both the parents and the patients ask. So it's not, so what are we afraid of when we stop? So that is also there. So we are afraid of regression when we stop. So when can we stop? When target visual acuity has been reached. So is target visual acuity always 6.6? So let's take this example. A 12-year-old with isometropic amblyopia due to high myopia of both eyes minus 12D. He has a BCVA of 6.9 now after maybe like 2 years of patching. Um, I don't expect the vision to improve beyond 6.9 in this child. So 6.6 is not always the target BCVA in many patients. So that is also to be considered. And if there is no improvement in vision after 6 months of part-time occlusion with good compliance, then we can conclude that the patching is not going to be effective beyond this time. And whatever BCVA has been achieved is the maximum that can be achieved with the patching method of treatment. There are newer methods of treatment for amblyopia that have come up recently, which my colleague Dr. Jayani will be speaking about in the next talk. So that can be tried in those individuals. So how to stop? The same thing. We are always afraid of regression. So the PEDIC studies reported 21% of regression, but in other studies, it has been reported from anywhere from 7 to 24%. So how do we go about that? So abrupt cessation can be tried, but usually a tapering, as with many medications or with, as we saw in morning, atropine also is always better. So usually how we stop is about 50% reduction every 4 weeks, and they have to be monitored uh, more closely during this period of cessation of treatment. So also, if they have not crossed beyond the amblyogenic age group of 7 to 8 years, they can be maintained. They can be maintained on at least 1 hour of maintenance patching. And abrupt cessation is definitely not preferred when there has been intense patching of 6 hours previously going on. You don't abruptly stop it to 0. We taper it to 4 hours, 2 hours, and then stop. And when the initial amblyopia has been very dense also, abrupt cessation is not very advisable. So there are a lot of problems of patching. We already spoke about the compliance. So that is one big problem of patching. Then since depending on the method that they use, there can be skin rashes, there can be occlusion amblyopia of the eye that is already occluded. Disruption of binocularity also has been reported, though it is still considered a gold standard of amblyopia treatment. We still have these problems to deal with. So my take-home points will be, so first treatment should be the elimination of the cause for visual deprivation, whether it's either a cataract or correction of refractive error. So we can give a time period for refractive adaptation depending on the age of the child and the severity. And we get our treatment guidelines from the PEDIC ATS studies. So one more point that the PEDIC studies have shown is that older children may also benefit from patching. So never deny a trial of patching. We may advise a guarded visual prognosis to the parents. So at any age, we can give a trial of patching. And ensuring compliance through proper counseling gives the best result for the child. Thank you.